The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. I see that we're starting to get some attendees joining the call. So it's just about 3 o'clock now. We'll give another minute or two until we get started, just to give some folks some more time to join. Good afternoon, everyone. We're going to get started here in another minute or so. We're just going to give it a little bit more time to let people dial in. So one more minute, and then we will officially start the presentation. Okay, so let's go ahead and get started. People, I'm sure, will continue to filter in and can jump in when they join. So, good afternoon and welcome to the first webinar of the RadSite Summer Webinar Series, MACRA Simplified: Why Pay When You Can Get Paid. My name is Brooke Incontrera, and I'm the Marketing Communications Manager for RadSite. And before we begin, there are just a few housekeeping items I wanted to mention. So this is the first of 3 webinars RadSite has planned for this summer. Information regarding the upcoming session and a recording of this session will be available on our website. We will also share a link to the recording as well as the presentation itself, and all of that will be emailed to all registrants within the next few days. Just keep in mind that all attendees will be muted. So we encourage participants to submit questions via the chat window in the GoToWebinar platform. These questions will be addressed at the end of the presentation, time permitting. I'm going to now pass the presentation over to our moderator, Dr. Arkeep. He is the founder and CEO of Cranberry Peak.
Well, thank you, Brooke. Before we get started, let me start by saying Happy Summer Solstice Day, everyone. Let's make good use of the longest day of the year to learn about MACRA. Thank you, the entire RadSite team, for hosting us. And a big thank you to everyone joining us live today and those watching this recording later on. My name is Nikolai Arkeep. I'm the founder of Cranberry Peak, and it's a privilege to serve as a moderator for today's webinar. Before we proceed, allow me to take a moment to briefly introduce the 2 speakers today. 2 physicians, one in private practice, one in an academic medical center, both experts in MACRA, both physician entrepreneurs. So we have Dr. Alex Tanase, a physician in private practice with deep experience in medical quality and data. He received several national and state awards for leading quality improvement projects. Alex is also the co-founder and CMO of Notovox, where he's using his successful clinical experience to disrupt the coding process. We are also fortunate to have Dr. Sean Gandhi, who is a resident physician at Massachusetts General Hospital. And as a side note, he's completing his residency tomorrow. He holds an MD from Harvard Medical School, an MBA from Harvard Business School, and a Doctor of Philosophy from University of Oxford, where he was a Rhodes Scholar. So let's see, what should we expect ahead? 3 different things. First, we all heard MACRA is an acronym, and it's an additional item on an already long to-do list. So Dr. Tanase will provide basic information on MACRA. Why was it introduced? What is it? What the timeline is? And how to optimize its impact on you and your practices. Second, since many of you are working in radiology, Dr. Gandhi will also present how PAMA and the appropriate use criteria program connects to MACRA. Finally, Dr. Tanase will provide additional simple, practical examples that will help you optimize the impact of MACRA on your practice. Most importantly, we hope that this is just the beginning of our conversation on MACRA and on transforming healthcare. It's impossible to learn everything about MACRA today, even though it's the longest day of the year. But it's possible that all of us together can improve healthcare delivery. So please reach out to us. You have our contact info or through social media. Would love to continue this dialogue. Having said all this, Dr. Tanase, would you like to get started by telling us why MACRA was introduced?
Good afternoon, everybody, and thank you for joining us. Let's start with why MACRA. Over the last 50 years, the healthcare costs have been steadily rising worldwide, but the biggest increase happened in the United States. Yet, this highest cost in the United States is not matched by better outcomes. In fact, a recent review shows just the contrary. We have the lowest outcomes for the highest prices. Over the last 30 years, several programs have been tried unsuccessfully to decrease costs and improve outcomes. In particular, the Medicare Sustainable Growth Rate program, implemented in 1997, had an inverse effect from what had been desired. Instead of increasing quality of care, it ended up incentivizing physicians to provide more services. It also led to a suggested 21% cut in Medicare reimbursement rate to clinicians in 2015. The introduction of value-based medicine to replace the fee-for-service payments had become a priority. Thus, the Quality Payment Program and MACRA were born in 2015. The framework for the current Quality Payment Program was defined by the recommendations made by the Institute of Medicine in 2001. The initial implementation took a decade and led to several federal performance programs like PQRS, Value Modifier, Meaningful Use, and the MOC. I believe you are all familiar with them. After 5 more years, those performance programs have been unified into the new Quality Payment Program. Now, instead of a 21% reimbursement cut, we have a value-based methodology, MACRA, the Medicare Access and Cheaper Authorization Act. You can participate in MACRA in 2 ways: MIPS, the Merit-Based Incentive Payment System, and AAPM, the Advanced Alternative Payment Model. Most radiologists use the MIPS option to report. MIPS provides bonuses or penalties based on how well a physician performs relatively to other physicians. The Advanced Alternative Payment Model uses MIPS comparable quality measures, but the participants need to meet additional criteria. The model is focused on coordinated and high-quality care. The rewards and risks are higher than myths. The long-term goal is for all organizations to transition to such an advanced model. One of the requirements is to bear more than a nominal risk, which is a percentage of revenue, so that the risk is based on the size of each organization. MIPS has 4 categories and a total maximum score of 100 points, which are split between the 4 categories. Most radiologists are exempt from the cost and promoting interoperability categories. The maximum positive and negative adjustments was 4% for the 2019 payment year, based on 2017 performance, and increases every year to a plus 9% for 2022 and future years. 3 was the minimum required score for the 2017 reporting year, and has increased to 15 for the current reporting year. The minimum reporting requirements for 2017 performance year allowed most of the eligible providers to avoid the 4% penalty, with only 9% unable to achieve the minimum 3-point required. This also translated in a small positive adjustment for those achieving a less than 70 points, as the distribution is based on a neutral budget. Outside of the budget neutrality requirement, an additional $500 million has been allocated for those accumulating more than 70 points. I will quickly review the category. This category accounts for a maximum of 10 MIPS points till 2022, when it will be adjusted at 30 points, which is going to change the quality category score also to 30 from currently 50. The cost category does not require additional submission from the clinician. Claims data is used instead, which makes the ICD-10 coding essential for the cost category. A quick note, that is exactly what Notavox does. It helps physicians improve their cost and quality of care through better coding. For 2018, there are 2 measures from which only the Medicare spending per beneficiary measure applied to some radiologists. This measure applies to clinicians that have at least 35 cases per year with Medicare Part A and Part B claims during a hospitalization episode. The episode lasts from 3 days before a hospital admission through 30 days after hospital discharge. This can apply to interventional radiologists as well as diagnostic radiologists involved in some episodes with significant imaging, like multiple trauma and transient ischemic attacks. Promoting interoperability is the new. It is very similar with the old meaningful use, and it depends on the EHR used. Partial reporting is allowed as long as the base score is achieved. This applies to less than 10% of radiologists. Next, I will focus on the quality and improvement activities, which apply to the majority of radiologists. Let's start with the quality measures workflow. During a clinical encounter, a clinical decision or intervention is made. At the same time, the payer receives billing information from which it gets different insights, demographics, the condition for which guidelines exist, and the service, which has a cost. Was the provided care of good quality? Let's say I want to document the quality, but how do you measure quality? And how is it recognized by both the clinician and the payer? There is a total of 271 MIPS measures provided by CMS available for the quality category reporting. A minimum of 6 measures need to be reported, or a full specialty set. For example, the interventional radiology set has only 4 measures available and sufficient for reporting. The reporting period is 12 months. One of the 6 reported measures has to be designated as either outcome or high priority. Reporting of additional outcome or high priority measures brings bonus points to the category score. Most measures are process measures. Here I listed examples for each of the measures types available: outcome, high priority, and process. Okay, now I have a number of measures I want to use. How do I document them? A quality clerk can review the charts looking for completed measures, and some billing codes may qualify as measure met. Example, mammography or colonoscopy done. However, such passive approach is the least desired. Documentation at the point of care is ideal and can be done through templates, paper, or electronic, or special codes provided by Medicare and American Medical Association. Such codes are sent as claims through the CPT billing process. Now, how many patients do I need to report? A minimum of 20 patients must be reported for each measure. Data is considered incomplete if the reporting is done for less than 60% of eligible patients. The eligible patients are recognized based on the ICD-10 and procedural codes submitted through billing for each clinical encounter. The reporting implies the documentation of the measure being either met or not met. The data obtained is used to calculate the completeness and performance rate. Now that we review the math, how do I submit the data to CMS? There are 6 reporting methods. The claims option is only available for individuals. The EHR, Qualified Registry, and QCDR reporting methods offer convenience in reporting while expanding the eligible population to all payers instead of just Medicare. The Qualified Clinical Data Registry allows additional specialty-specific non-MIPS measures, which is important considering that there are only 14 MIPS measures for the diagnostic radiologist. The benchmarks used for scoring are specific to each reporting method. One reporting method is allowed for each category. Choose the one with the highest rating if multiple options available. The ongoing status can be reviewed on CMS QPP website or through EHR and registries. Now that I have chosen my reporting method, how does it work? The EHR and registries aggregate the data in a standard format like QRDA, which can be uploaded directly to the CMS website. Registries can receive data from clinicians as a manual entry, text, or Excel file, and as electronic formats from EHRs or other electronic data capture tools. CPT-2 and HCPCS codes can be sent directly to the payer. Data documented and transmitted electronically to CMS without any manual adjustment is considered certified EHR end-to-end reporting. Additional points are earned for each quality measure or clinical improvement activity reported that way. The accuracy of reporting can be verified only through audits. This can occur up to 6 years after data submission, and those audited will have to respond within 10 days. Now that I have reported my data, how is it measured? Quality points are based on benchmarks. The benchmarks used for 2018 reporting period are based on the 2016 PQRS data and possibly on current performance period if sufficient reporting occurs for those measures without an existing benchmark. Your percentage met for each quality measure is compared with the benchmark for the reporting method chosen, and a percentile is assigned. Each reporting method has its own scale of decile, which means that a small percentage through one method, for example, qualified registry, may be scored the same with a higher percentage through another method, for example, QCDR. A low performance rate for an inverse measure corresponds to a high decile and number of points earned for that measure. Some measures that have been found to be very easy to report and have a very high performance rate are considered topped out and eligible for maximum 7 points instead of 10. When multiple reporting methods are used, for example, EHR and registry, the highest performance rate is applied. A specific status has been assigned to each clinician, and you can review your own MIP status on the QPP CMS website by logging in with your NPI. The status may vary based on the choice of reporting, individual versus group, including the virtual group, which is a new option for the solo practitioners or small groups of less than 10 clinicians. There are advantages and disadvantages for each of these options, with individual reporting being limited to the Medicare patient and having the claims option, while group reporting gives access to more measures and resources. An estimated 70,000 participants in an advanced alternative payment model will be exempt from MIPS reporting, as well as an estimated 80,000 clinicians who are considered newly enrolled, no Part B charges in 2017. Additionally, 540,000 are exempt for having less than 200 Medicare patients or under 90,000 in Part B charges, which include the copays. All other clinicians are automatically included in the MIPS reporting process. The criteria used for exemptions leads to a preferential selection of larger practices and subsequently more competition for the bonuses. If a clinician moves to another organization, her or his NPI base score will be applied to the new organization. Clinicians with special status are eligible for partial exemptions as well as bonus and extra points to account for their unique circumstances. Most radiologists are considered non-patient facing clinicians, which means that no more than 100 patient facing codes per year are billed. If more than 75% of providers in a group are non-patient facing, the group is non-patient facing. Clinicians with special status are exempt from the promoting interoperability category reporting, and some are eligible for double improvement activity points, which include the non-patient facing clinician. Hardship exceptions include small practices. Those with hardship exceptions are exempt from the promoting interoperability reporting. Small practices are also eligible for additional bonus points for the quality category and overall score, as well as double improvement activity points. The other important category for most radiologists is the improvement activities. The activities have assigned two types of weight: medium, worth 10 points, or high, worth 20 points. The reporting period is 90 consecutive days. Any improvement activity is required to be reported by at least one clinician in a group and can be reused every year. The necessary 40 points for the category can be achieved by reporting 2 high-weight activities or 4 medium-weight activities, as well as combinations of the 2. Double points are awarded to non-patient facing clinicians or groups, which means that by reporting of only one height-weight activity, the maximum 15 points are earned and penalty is avoided. There are some examples of high and medium weight activities. Next, Dr. Gandhi, we're going to discuss a specific example of a high weight activity, the consulting for appropriate use criteria using clinical decision support when ordering advanced.
Thank you, Dr. Tanasi. So what is interesting about appropriate use criteria is that it's a high weight activity that has specific consequential effects on radiology practices. A companion program to MACRA, which is the Protecting Access to Medicare Act, or PAMA, was passed in 2014 because Congress was concerned about the rising costs of advanced diagnostic procedures for Medicare patients. This included radiologic, laboratory, and cardiovascular studies. They focused first on radiology studies. Confusingly, though, the purpose of PAMA was to reduce the cost of inappropriate advanced diagnostic procedures, but rather than focusing the penalties on the physicians ordering these procedures or tests, PAMA actually authorizes reimbursement penalties for the radiologists when studies are performed and without the use of appropriate use criteria. So, for example, if an outpatient physician orders an MRI of a patient's brain because the person was complaining of chronic headaches, but does not use a CMS-qualified clinical decision support mechanism to determine the appropriateness of that order for the MRI, the radiologist, so not the referring physician, but the radiologist who performs and interprets that MRI actually is penalized financially. This is why it's very confusing. The specifics of the actual penalties themselves are still being determined by CMS. At the same time, MACRA, not PAMA, but MACRA offers financial incentives, as detailed by Dr. Tanasi, for referring physicians using appropriate use criteria as a high weight activity. So to summarize, once PAMA goes into effect, advanced imaging tests, particularly of importance for diagnostic radiologists, will now require evidence of use of a clinical decision support mechanism by a referring physician to ensure appropriateness of the test and also to allow the radiologist to be reimbursed fully for performing and interpreting the study. But, of course, there are patient-facing radiologists, and of course, as detailed by Dr. Tanasi, there are incentives available for use of clinical decision support mechanisms for appropriate use criteria. Because clinical decision support mechanisms are a high weight improvement activity, even one physician documenting use of such a mechanism could add 15 points out of a total of 100 to the overall MIPS score for an entire practice. On the right on this slide, you'll see an example of what one of these mechanisms looks like, which is a CMS-qualified clinical decision support mechanism called EasyCDS. This platform offers referring physicians an intuitive point-of-care system for incorporating clinical information and appropriateness use criteria when they order an advanced diagnostic radiology study. And with that, I will turn it over back to Dr. Tanasi to discuss practical tips for maximizing reimbursement.
Thank you, Dr. Gandhi. So next, let's use a scoring example. For a small practice of non-patient facing clinicians. The group is exempt from the promoting interoperability category reporting and from the cost category, having less than 35 cases per year for the Medicare spending per beneficiary measure. Therefore, those categories points are added to the quality category for a total of 85 instead of only 50. Let's consider the scenario where 6 quality measures were reported for a minimum of 20 patients, but less than 60% of eligible patients, which qualifies as an incomplete reporting. A small practice is awarded 3 points instead of 1 for each measure with minimum reporting for a total of 18, which represents a 30% of the total possible 60 points for the category. Given that quality represents now 85 of the total overall score, the practice has earned 25.5 points for the category. Use of a high weight activity together with the double point bonus for non-patient facing allows the group to earn the maximum 15 points for the improvement activities category. A small practice 5 bonus points are also awarded. There is good recent data showing that patients requiring imaging are of higher complexity overall. These can be recognized through the ICD-10 code submitted. Therefore, radiologists can be eligible for the complex patients bonus, which can bring up to additional 5 points. The total score of 50.5 points will bring this practice a bonus in 2020. Let's now consider a similar scenario as before, but reporting for more than 60% of eligible patients, and with 50% performance rate for each quality measure reported through a registry. For example, corresponding to the 6th decile and 6 points for each measure. The total score obtained of 76 points makes the practice eligible for additional exceptional performance bonuses from the $500 million allocated each year between 2019 and 2024. The transition to value-based payment model has started and will continue, not only for CMS, but also for the private payers. A successful transition is highly dependent on clinician champions and a reporting infrastructure embedded in our daily workflow. In summary, you should know your MIPS status. Choose reporting that works for your work. Minimal reporting is the beginning of competing, not just avoiding a penalty. Your reporting this year will influence your reimbursement in 2020. Your future financial success depends on your approach towards MACRA. Take the lead or fall behind. Thank you.
Thank you, Dr. Tanase. Thank you, Dr. Gandhi. Extremely practical presentation. I hope you all agree. We didn't solve MACRA yet, but we took some great steps at least to understand what to expect and how to optimize it. We have a few more minutes ahead of us in this webinar. So with that, we should open now the conversation to the audience. So we're going to take a few questions from the people who joined the webinar. I'm looking through the questions. I'm going to start with one quick question for our speakers. Can we report as an individual for a category and as a group for another one? Any of you wants to? Dr. Gandhi, Dr. Tanase?
So Nico, I can answer this. The reporting has to be done together. So basically, if you're part of a group, the reporting is done as a group, and it's done for all categories. So once you decide that you want to report as an individual, all categories are reported as an individual. And the same when you decide to do the reporting as a group. So the answer is no.
Thank you, and thank you to all of you who posted the questions. Please feel free to ask more questions in the chat box. We'll be able to see, and we'll try to address as many of those questions as we can today. Here's another question that we received from our audience. What is the deadline for a virtual group application?
I can actually answer this one. The deadline is the end of the year prior to the reporting year. So for the current year, 2018, where actually the virtual group application was introduced, so this option was not available in 2017 reporting year. The deadline for this year was December 31st. And the same is going to apply for 2019 reporting year. The deadline will going to be December 31st, 2018.
Excellent. Another question we got is, how is the payment adjustment decided when dealing under multiple taxpayer identification numbers?
For each taxpayer identification number, there was going to be an adjustment which is going to decide the payment for that specific group. So when a radiologist actually applies with multiple taxpayer identification numbers, we're going to receive adjustment from each entity that actually was part of. So basically, that radiologist is going to have a sum of adjustments from each entity under which was had applied as a group.
Excellent. Another question we got is, if we report as a group, will it be scored also individually, where there will be only one overall score?
Regarding the group, there are going to be only one overall score. However, it's important to mention that CMS will have an individual score for each provider based on the NPI. That information will going to be used, so comes in handy when a provider moves to another institution, to another group during the performing year. So that specific score can actually be moved to the new group, the new TIN entity. So even though the reporting is done as a group and scored as a group, there is an individual scoring, but it's used only for this specific situation.
Very good. Another question that came from the audience was, what is an APM? Dr. Gandhi, do you want to take over the question?
Absolutely. So an APM is the other arm of MACRA besides MIPS. MIPS is primarily focused, as Dr. Chudnovsky mentioned, on providers and physicians who are operating under a fee-for-service model. The alternative payment models, or APM, are an approach that MACRA has to incorporate innovative new ways of reimbursement. So, for example, for those of you on the call who may be part of a large academic center, or are part of an accountable care organization, or part of a CMS Innovation Center model, or if you're earning payments through the Medicare Shared Savings Program, those are all programs that would qualify you to meet the criteria of MACRA through APM rather than through MIPS.
Another question we got from the audience was, if one provider is new to the group and MIPS reporting, will he be excluded from the scoring process? Dr. Tanasi, you want to address that?
Sure. So even though it may make sense that this new provider may not have the volume, may not actually be eligible on that specific, requirement, or even though we may think that it's considered as new in terms of enrolling in Medicare. Because of the group reporting, the group actually option, that specific provider will be included. So no providers in a group are excluded, with one actually exception in an academic actually circumstance where the first year residents are not included. So that will be probably the only circumstance where a new provider will be excluded from the group reporting.
Excellent. Another question that came was, does the quality payment program apply to private insurance companies? Dr. Gandhi?
Currently it doesn't. The quality payment program applies primarily to physicians who are getting reimbursed under Medicare Part B coverage. But if you again recall the other arm of MACRA, the alternative payment models or APM, there are some models under APM that incorporate private payers or Medicaid, and so there would be an effect on private payers and Medicaid under that system.
Any other questions from the audience? Feel free to ask them in the chat box. We can give you another minute maybe to if you have any points, even practical questions, please feel free to ask them. We'll do our best to address them. A minute or so, just to.
Nico,
yes.
And Nico, even if actually questions occur later, they can actually be sent through emails. We'll be more than happy to address them that way.
Thank you. We got another question. What happens if a physician is moving from his current practice to another one halfway through the reporting year?
As we mentioned, there was a similar question earlier. So the score that was actually acquired up to that specific point based on the provider's NPI, that specific score was going to be carried over to the new group, to the new entity, or if the provider decides to start reporting as an individual, that will going to apply to the individual reporting. So basically, the score based on the NPI is carried over to the next entity that the provider is joining. And by the way, this is actually important because when a new provider joins a new group, this can actually be a strong point or a point that can bring the new entity down in terms of scoring. So it's interesting that when a new provider actually joins, by bringing a new set of score, that can actually have an impact in the whole group.
Excellent. We got another question. What are the overlaps of FFS and VBPM? You want to take?
Yeah, so go ahead, Dr. Shansi.
Absolutely. So currently, the fee-for-service is still the predominant reimbursement method. However, a part of the AAPM, the reason we mentioned the advanced alternative payment models is because they are exempt from MIMS. But in fact, there are partial advanced payment models which actually receive some points even though they are not exempt from MIPS. They actually receive points through the MIPS option. But a part of this reimbursement, the accountable care organizations have been using the value-based model. So even though the measures used may not actually be based on the CMS measures, still the concept is the same. ACOs decide actually in a direct discussion with the insurer which measures were going to be used for that specific ACO, and those specific measures will determine the reimbursement, the bonuses, or the shared risk, depending on the accountable care organization structure. So there was going to be a value-based reimbursement model, and this has been actually going on for a long time. And in fact, more and more organizations are moving towards the ACO model with major insurers. And the major ones using accountable care organizations are United Healthcare and Aetna.
Well, thank you. Looks like there are no other questions. I'd like to say thank you again to our speakers, Dr. Tanase, Dr. Gandhi, to all of you joining now, and to those of you listening to the webinar at the later stage. As mentioned at the beginning, we hope this is just the beginning of our conversation. So please reach out to any of us through email, through Snowmail, through social media, Twitter, Facebook, LinkedIn, whatever will make this conversation easier. We'd love to continue it and share this journey with you. Enjoy the rest of the longest day of the year and have a wonderful summer, everyone.